a product if the seller is also on Amazon. But if we create a payment matlab like unified health interface which is on the right hand side, then the provider and the user could be on different platforms, but the citizen can make use of them. It's like it's generally given example like emails that we have. We can do email from Gmail to Yahoo or Yahoo to Hotmail, etc. So the common protocol say it can do. So these are the three registries that we have. ABHA, which is a randomly generated 14-digit number, and then professional registry and facility registry. We want to maintain them as single source of truth and across India and only one. So ABHA is a randomly generated that we have already seen. There are no, you cannot guess anything from those 14 digits. Next. ABHA app is already available on the Google's App Store, or it is also going to come on iOS in some maybe 1 or 2 weeks now. Next. These are the professional registries where we want to maintain a single source of truth of all the doctors and of different systems of medicine, nurses, and other healthcare professionals. So they will be given unique professional ID, so that they can be made then available on the UHI. Health facility registry is again a registry or a single source of truth where unique identity would be provided to different system or different hospitals having different systems of medicine. So it will also cover the clinics, the laboratories, blood banks, etc. This is the funding part of ABDM. It's a 1600 crore spread around for 5 years. We are in the second year of it, and it has different heads like digital IT systems, management, salary, HR, IEC, CB, etc. that we already know now. Next, please. The proposed governance structure, I think for this we have already circulated 8th March guideline where this governing structure can be made by all the state. They have complete flexibility to do it. It should be headed by SMD, and then he should be supported by joint directors of IT coordination and admin and support, and then they can also deploy PMUs and PMCs for their work. State has complete flexibility to do it, and guidelines are quite have been circulated in March itself. This is the public dashboard. I have taken a screenshot of it here. This is how it shows it. Every state can have their own figures here, and it is available to everybody, and their drill down is also possible to the district level right now, and different facilities, trends, etc. is also provided here. Next. So these are the expectations that we are expecting from all of these states now, that the population of registry or the building blocks is to be done in a mission mode. We have also written letters to medical councils, SMDs, etc., all the state authorities to get these registration done on a mission mode. I think in this western region, Goa and DNHDD has done, and Maharashtra in the last 1 month has done a quite fabulous job in health facility registries. At least we are still lagging behind in professional registry. We'll come to those figures in later part of the presentation. And then we should have a statewide HMIS which should be deployed in all of the facilities in across the state. It should be cloud based. We'll come to the requirements that should have any HMIS should have in a state. The governance structure should be established by the state. Some states are yet to establish their governing structure. Next. Then we can create some model facilities of ABDM in the states, and then strong IEC information and communication. This has to be done in the states so that we have good awareness of ABDM across state then. So let me come to the western region now. Western region consists of these 5 states and union territories. We can see that the organization mission directors have been appointed in all of the 5 states, but yet nodal officers for HFR, HPR are yet to be appointed for Goa and Rajasthan. And there were other joint directors, etc. Those also has to be done in, I think, Rajasthan and Gujarat. Implementation, as we can see, Maharashtra and Goa has done quite a good job in the last 1 month, where they have got their facilities registered. At least public facilities, they have achieved good amount of saturation. But for the private facilities and the private professionals, all the states are yet to get a go ahead on these. Gujarat and Rajasthan are still lagging behind in registration of the facilities. The banking arrangements, or as it is a centrally sponsored scheme, and we are requesting, this is the first and foremost ask that we are doing from all of the states, that they should give us the details of their central nodal agency as per the OM which was sent to all the SMDs. We should have a bank mandate form, and the budgetary proposal, if the state is going to provide us, it should be supplemented by some documents, so that we can get it through quickly. We are also empaneling some HR agencies for PMU and PMC. We are empaneling them on technical bids. The commercial bids the state can do, and they can employ any empaneled agency which is empaneled by NHA. This tender process is is in the final stages as NHA. So maybe in a couple of weeks we are going to empanel some of the HR agencies for which the state can directly do some limited bidding, commercial bidding, and then can deploy some HR agencies for their state. This was the recent development, that software development agencies have been empaneled by NHA. There are 12 of them, and the state can use them for their software development needs, or the terms of scope which has been mentioned in the RFP. And the integration related part to ABDM, or any software that the state is using and it has to be integrated with ABDM, that financial support can also be taken care of by NHA on case-to-case basis and on request basis. We are also thinking about giving some incentives to various stakeholders and players of ABDM. These are the 5 kinds of incentive schemes that we are thinking of. We are thinking of incentivizing the state and UTs and their ABDM team. We are also thinking of incentivizing the stakeholders and players in ABDM, like HMIS players, or any person who is going to deploy HMIS, or any doctor who is generating a digital health record. To recognize the work already done by the state team, and to build up capacity of the state team through domestic and foreign visit exposures. And we are also thinking of getting some positive competition among the states, so that ABDM can be adopted as early as possible. This was the thing that I was telling, that HMIS, for the HMIS we have come up with MVP guidelines. It's in version 2 now. Version 3 also we are working upon it. So MVP guidelines are like that minimum variable product if the state is going to purchase any HMIS. There are many HMIS available in the market now. 2 of them from government, e-hospital and e-Sushrut, are already integrated with ABDM. 4 or 5 others, private players, their HMIS is also integrated and compliant to ABDM. Those also can be purchased by state and can be put to use in all the facilities in the state. The only suggestion from NHA that only the compliant, ABDM compliant HMIS should be used, and these guidelines can be taken care of, can be referred to if the HMIS is compliant to or not. The guidelines consist of features that are mandatory or suggested or suggestive in HMIS, LMIS, and we have also come up with some comparison feature on our website, where the stakeholders can compare what features are there in what HMIS. It eases the decision making process. Next, these are the desired features in any HMIS, and HMIS should be cloud based, should not be client based or the premise based. It should be cloud based and end-to-end integrated, not one module only. It should have all the modules. It should be cloud based. It should auto populate the records, should have some favorite lists, should have some predictive technology, and speech to text conversion is suggested. Mobile and web compliant or mobile app is there, then it's good. I have also taken a screenshot out of the MVP guidelines. Can you please on next slide please? So this is how MVP guidelines looks. Whether the HMIS can create a ABHA, it is mandatory. Verification of ABHA, sharing of QR code, etc. So should have, must have, that kind of features are already present in the HMS MVP guidelines. Next please. This is the contact slide. If any person can contact us on, it is also available on our portal. Next, please. So if there are any questions from the state related to funding or banking arrangement or HMIS, you can also contact me later on. Next, please. Thank you so much. This was my presentation.
Thank you very much, sir. I now request Mr. Rohit Jha, Deputy Director, SPC Division, NHA, to kindly give a presentation of Ayushman card saturation.
Good morning, everyone. Good morning, sirs and ma'am. I'm going to talk about one of the issue which is very important currently, and it is being very strongly followed by NHA with all the states. And why it is so, I have a presentation, but since this presentation has been made so many times, so I find it easier to convey my message by a general dialogue rather than I will go through the nitty-gritties of the presentation subsequently, but before that I will just brief you why this topic is so important and why do we need to have a separate presentation on this topic. So what happened that when PMJ was launched in 2018, then it was SECC, Socio-Economic Class Census 2011 data was considered as the base data for beneficiary identification. However, in the cabinet note which was approved for the launch of the scheme, it was very clearly mentioned there that the states which are implementing their own scheme with a larger beneficiary base, they can continue to use the database which they are having. However, in a quote unquote the word was in a reasonable time frame, they have to map the SECC data with the non-SECC data. So we have two categories of states. One, which we call greenfield states, which have started the scheme new. I mean, like they have before the launch of the PMJY, they do not have any schemes. Okay, and there is another set of states who have their scheme running well before then PMJ was launched. Okay, so now what happened that many of the states who are implementing state scheme before the launch of PMJY, they were having a database. Using that, many of them have already issued some kind of beneficiary card, or many of them have probably uh, like in case of Telangana, I know they have a ration card. Even in case of Maharashtra, they have a ration card, and the ration card itself is good enough for the beneficiary to visit a hospital and avail the services. Recently, Rajasthan has a Jan Aadhaar, and then person can go and take the services with their Jan Aadhaar card. However, this, as I was saying you, that this expectation of matching the SCCC versus non-SCCC, this could not fructify. Why it was not possible? Because SCCC database does not have any common identifiers to any of the other larger beneficiary database. Like if I talk about ration card and FSA, and if I talk about SCCC, there is no common identifier. So I can use some kind of fuzzy logic, some kind of name matching and all that with the to identify ki Rohit Jha of ration card is same Rohit Jha of SCCC database. But with 100% certainty, I cannot say even single person that this is immutable. The matching is immutable. That we cannot really qualify that. Now, so what happened that some states have genuinely tried to match the SCCC with the non-SCCC. Some kind of matching exercise was done, but they failed. Majority of them failed. Okay, and what happened till the date? Till today, I would say you that roughly around 6 crore cards have been issued. Ayushman cards have been issued on NHS IT platform. 6 crore of SCCC card have been issued. Okay, I can tell you for clear. Of these, you can see the map here. We have 13.71 crore cards. Of these, roughly 6.5 crore is SCCC. Rest of them are non-SCCC. So many of the states are implementing non-SCCC database on our platform. So what happened now? What the problem happened? The first one is that we could not implement the mandate of the cabinet of the government of India that we could not map the beneficiary.
in many of the places, what happened, NHA didn't get the visibility about the beneficiaries. Like we are like NHA, if I talk about that, who are the people who have of this, like suppose today around 3.5 crore beneficiaries have availed, not beneficiaries, 3.5 crore hospital admissions have been authorized under the scheme. There is a lack of visibility that who are those 13.5 crore beneficiaries who have availed the services. And now this is about, like there is some kind of, I would say, identity of the scheme for these 13.5 crore, like these 3.5 crore, majority of them is missing. Why it is missing? Because they somehow, the poor people who are availing the services, they do not know that if there is, many of the places do not know if there is something called Ayushman Bharat PMJY, because many of the states where there is already a scheme running, and I understand that majority of you would agree with the fact that the beneficiaries there primarily know the state scheme, where like even if I talk about Rajasthan, even today people know that there is something called Bhamasra. There is not even the GITB Yojana, which you guys are not listening, is not very, like मतलब अभी उतना popular नहीं हुआ है, अभी भी लोग, even if I talk about my NHA people, many times they refer that Bhamasra scheme and all, something like that. So this was also a kind of concern that why there is lack of visibility about PMJY, why there is lack of visibility about NHA. Now coming back, what was the solution? The solution was that we replaced the SSC database with some kind of other database and say that we are adopting a different database. Now, if SSC are there in SSC, but there were certain deprivation criteria, like 6 of them, and there were 11 occupational criteria. Try to do some kind of, database sort of, we try to find out a database which could probably get the exact number of 10.75 crore beneficiaries as we are currently implementing, but we could not get a, like if I talk about ration card, that is NFSA, we have around 19 crore families. So that is the cabinet of government of India has allowed us that we can go ahead with the 40% of the poorest, of the bottommost poorest families. But ration card caters to 67% of the beneficiaries families. So that was not again, matching to the mandate of the government of India, which we have been asked to implement. So what we did, then subsequently you must have received that poem, and recently again a poem 4 5 days back was issued by the Ministry of Health. Now we have allowed the flexibility to the states. Whatever database you want to implement, you can go ahead. NHS is not a big problem. We assume that the SSC database is, I'm just, we are talking within of this cabin, so I can say that SSC database is like a dead horse. There is no point in, like keep on expecting that there is something going to come out of that. So we tried for 3 years. There are many states who have really done good work. Like if I talk about Jammu and Kashmir, they have been achieving 70 to 80% of beneficiary identification. We have we have some other states who have done also good, but there are majority of the states have who are doing good in this scheme. They have not adopted the SSC database. So now what we are saying that please go ahead with whatever database you have. We do not want to thrust upon you the SSC database. You adopt whatever database you are implementing. But the first thing is that, of course, because the cabinet of the government of India has asked us to implement SSC. So first line we say that please see that you are able to saturate SCCC. However, if you fail to do so, or if you feel that now you have achieved some kind of saturation and there is no movement in the SCC database, what you can do, whatever database you have adopted, of that, now suppose there were 100 SCC families to be targeted in, suppose I take the case of Maharashtra, there were 100 SCC families which were to be which are sponsored, co-sponsored to the government of India. Now Maharashtra have been able to identify 20 such people. Now 80 are left. So we say that for these 80 people, you can adopt any other database. Give us 80 names. We do not prescribe any kind of guideline for that. That who are those 80? It can be any 80 random people. However, of course, the state would also give us those people who are genuinely, like because PMJY is is a scheme for deprived and those people who are needy. But if I talk about Maharashtra, it is also implementing. Near USC, similarly Rajasthan is implementing, Goa is implementing. So we do not want the ATL category. We want people who fit into the beneficiary specifically typed for PM people. Give us those 80 people. And that is what we are called tagging. So we will tag them, these 80 people which you will provide us, 80 families I am talking about, we will tag them as SECC, or we will tag them as centrally co-sponsored beneficiary. It can be any 80 people. Now, what is going to happen? I will now either you can, like many of the states are implementing the uh, like we have three IT platforms, that is hospital empowerment module, Registry Identification System, and Transition Management System. So what we say that you can give us like Andhra Pradesh has given now, like Karnataka has given now, those who are not implementing or not implementing the new HR system, they have given us the old database. Like they have, suppose Karnataka is providing the 1.6 crore family, they have given us database for all 1.6 crore. Similarly, Andhra has given us. Majority of the states, Rajasthan has not given us. Maharashtra is processing their database, and Tamil Nadu region is processing their database. So we say that of these 1.6 crore, 1.5 crore, 1.4 crore, whatever the database, you can select the beneficiary family. So we will not select it like issue to know, issue to know. We will randomly run a logic in the system, and we will try to have a parity across the districts. So suppose there is a district called Satara in Maharashtra, and in Satara there were 100 SCCC beneficiary. So we will see that roughly 100 people are selected from them. It can be 5K up and low, but more or less it should be in parity. That is what tagging is called. I hope I'm able to explain this tagging process. If there is any confusion about that, kindly let me know. I will explain it again. This is called tagging. Simply, non-SCCC family give us, we will tag them as SCCC. Yes, sir. माइक दीजिए बोल रहा है हाँ actually I have not able to get clarity. At the one end, able to we see decentralized database, decentralized database. At this end, we are asking them state should build the database. Since in Rajasthan, we don't have database with our side. It is with the Janadhan authority. It's like in the back end, it is NAM. There is no doubt that the data is fetching because it's a single card for the everyone. So if it is decentralized, we are asking if you do tagging to the tell the Janadhan authority, 40% people will do the tagging. CAG or anybody can do the audits that these people have taken benefits from this. Because 60-40 ratio, we have applied. So why we are asking for the data? Because there is no given. I clearly see Janadhan authority will clearly deny why we give data. Because
उसका
we are
स्ट्रीम की
asking
दो ना
them,
मुझे
they
वापस
will give only concentration and
उधर
tertiary
दिख रहा
percent
है
will go if you want to get in next 20 years. That's what it is. Now here I will explain you why do we give. And one thing also, sir, regarding the public accessibility, this money is for the next years. First of all, Rajasthan, Bhausha cards distributed. Then same database name changed to Janadar, they distributed cards, and now Ayushman card. There's wastage of money of 50 rupees. I think that we should look at that wastage. Where we are wanting, because people are not bringing the cards. Okay, I will don't even have know our Aadhaar cards. Because 90% people don't know their Aadhaar number. Then we are creating new everything. And it is on the back end Aadhaar link. Rajasthan database, all Aadhaar link. CAG has done the audits. 40% we will tell them, these 40% you tag, you can tell which percent. Instead of asking the data, no, we don't want to build the system. From my side, I think from my side, I explain it so we can then subsequently that whether it is like possible or not. But answering your questions that why we need the database first of all, we need the database for following reasons. The first one is that we have been paying on pro rata basis. We have been paying like you have to keep the states who are implementing this scheme. They told us that these are those 60 people. Like suppose if Rajasthan, if I talk about Rajasthan, is implementing the insurance mode. However, those states who are implementing in a hybrid or a trust mode, they have now suppose they spend 100 rupees. They told us that we have spent 100 rupees and we were providing benefits to 100 beneficiary families. So what you are supposed to do, and out of these 100, suppose 60 are SCCC. So they said that you assume that if 100 rupees has been spent on 100 families and you are sponsoring 60, you pay us 60% of the 60. So now that is very, like it is that NHS is NHS to a funding agency. Okay, that's not just you see that NHS doesn't have any visibility about that, and NHS is just providing a fund for the implementation of this scheme. It's okay if there is certain small states or in large in a hybrid mode states because ultimately it is the premium which has to be paid cross to the commerce. But in trust mode states, we do not have the visibility that which are those people who have been provided treatment. Now suppose if I talk about Hmis. So if I say you that 40%, bottom 40%,
or the people. So are the bottom 40% are catered to. Now this is the first thing. The second one was that, being very candid about the discussion, please do not take it otherwise. It is about that is what NHA is thinking about, or the government of India is thinking about. The second one is that if beneficiaries are there with us, we also would like to run different kind of triggers. Like we want to see that there is duplication. Now we are converging multiple schemes, and you will be surprised to know that CAPF, Ayushman PAPF we are implementing, CGHS we are implementing, and there are common beneficiaries between CGHS and PMJY. There are common beneficiaries between Ayushman CAPF and PMJY. So those people who are government employees and they are taking the benefits of CGS, Central Government Health Scheme, they are also taking the benefit of PMJY. So we want to run a deduplication. Second thing. The third one is that we want to have the third and the foremost thing. The foremost thing is that, the most important thing is that we want to issue a Ayushman card to each of them. And why do we need to that? I will tell you. You said that we have issued Bhamasah card, we have issued Aadhaar card, we have issued some other card to the beneficiaries, and why do we need to issue? That is called recall. If you go to the BCC, that is behavioral change communication, it is very important that because you are providing a free service. You are not asking them to pay a premium if you would have asked them to pay ₹5 at the end of the every financial year. So well, I can understand like literate state or people who are where there is a behavioral aspect where people are very much health seeking behavior. Like if I talk about Kerala and also about Maharashtra is also one of such states. Even Rajasthan, because Bhamasha was being implemented for quite some time. But what about Bihar? What about Uttar Pradesh? People there, they are not aware about their entitlement. Even if you tell them, government of Bihar has recently launched that they are going to implement this scheme using ration card. Even if you tell that what is the level of awareness? It is 15%. We have done an independent third-party awareness, and 15 crores of rupees has been spent on IC, and 15% people are aware. Whenever they need, they do not really are able to get the services because they are not really aware about that they are entitled for something called Ayushman Bharat PMJY. Now how this is going to help, I will tell you. This is going to, if I do a re-verification, Jan Aadhaar scheme, if you talk about your Jan Aadhaar, which is your identity card, or Aadhaar if I talk about, Aadhaar, by virtue of my possession of Aadhaar, I am not eligible for some benefits from the government of India. Only if some other scheme tells that Aadhaar becomes the eligibility, or if someone tells that, in your case, even Jan Aadhaar, that 20 schemes would be run using Jan Aadhaar databases. But they would be using different chunks of Jan Aadhaar. They would say that, okay, bottom 10%, bottom 20%, bottom 30%, whatever. So how do you communicate to them that they are eligible under this scheme? Till the date, we have been able to repeatedly, I will say you, of the 3.5 crore, what is the unique beneficiary profile? We have been able to provide only of these 45% families are unique. So it's the repeat services. एक बार जो आके सर्विस ले लेते हैं, वही बार-बार सर्विस लेते हैं. और जिनको पता ही नहीं होता है, वो कभी सर्विस लेने नहीं आते हैं. And they are the people, they always remain sort of unempowered, they always remain, so they need to be told that you possess a card, that card basically tells you, that's a recall, it's not a smart card, it's 20 rupees card, it's a plastic card. Before that we told, even Ayushman Bharat when it was launched, it was called e-card. You are not supposed to give a paper card, like RSBI used to give a smart card, but subsequently then they started giving a paper card printed. They thought that okay, paper card लोग उसको पॉलिथीन में बंद करके रखते थे, फिर भी वो फट जाता था, ये हो जाता. Now this has been decided to give a plastic card. This has a very important, behavioral and recall value. under the BCC. That is, or IEC if you talk about that. And that is why it is being, and it is now, we are completely struggling. I'm telling you, NHA, we are thinking about, we have recently had a Chintan Sivir where the Honorable Health Minister was there, Union Health Minister. It was said that how we can create a recall कि बंदा को पता हो कि तुम आज भी eligible हो स्कीम के अंदर और तुम services ले सकते हो. That is a big challenge, to make the poor educated and empower them. Otherwise, if the 40%, if I talk about, if NHA is catering to, Ayushman Bharat is catering to 40%, of these 40%, 30% would keep on receiving the services. We would keep on celebrating that, okay, service scheme बढ़िया चल रहा है, 3% लोग service का benefit उठा रहे हैं. बट जिनको सबसे अधिक जरूरत होता है वो अभी भी या तो सरकारी अस्पताल में, मतलब सरकारी अस्पताल में तो अच्छी बात है, सरकारी अस्पताल जाना इट्स अ वेरी गुड थिंग, बट हाउएवर इवन इफ दे नीड द बेनिफिट दे विल हैव टू सेल आउट देयर प्रॉपर्टी एंड एवरीथिंग टू सी दैट दे आर एबल टू अवेल द सर्विसेज. दैट इज व्हाई दिस आयुष्मान कार्ड, एंड इट इज नॉट समथिंग one it was not something it was thought of as a and let me tell you, we will come back to we will show you a card which we have previously. It was a unique type of card. This time we made it that it is a tricolor card, so that there is no sort of sensitivity attached to this card design. We are primarily focusing on that each of these beneficiaries should be made aware. How we are going to make them aware that you are the beneficiary of the scheme wherever it has been. Look at the Kerala, the utilization is fairly good. Even if I talk about Maharashtra, this utilization is good, but I would, even PMJ was 3.5 crore, but if I see the number of unique beneficiaries, it is very less. Same people are going again and again. Dialysis जो ले रहा है वही dialysis साल में जिसको 3 बार dialysis होना है वो 52 त्रिक like 150 plus 156, 156 times they will take the service and will count 156 pre-authorization under this scheme. We are happy that 3.5 crore people have been, but if you genuinely want to reach out to the people, we need to reach out to them. We need to touch them, touch base them, and that is why this Ayushman card has been. This is a pure plastic card, nothing. There is no virtue in this. You throw this, still you can go and avail the services. You do not require PMJY ID or card to avail the services. You are right. There is no kind. This is the card we have talked about. Now look, we ensured that this is a tricolor card. This is a new revamped card which we are implementing, where we are ensuring that this is co-branded, this is properly, and there is no semblance of any kind of sensitivity attached to this card. Now coming back to the process, so after the tagging is done, what we are thinking that we will issue the Ayushman card to these beneficiaries, and that is why the database is required in our BIS system. And most importantly, the functional part of this activity is that we are going to provide portability services, which is hampered if you do not have this card. So if you take if Rajasthan Janadhar you carry and reach it to Bihar, or if you go to Kerala to avail the services, you will not be provided. In the first instant itself, the hospital would say that kahan se aaye ho, ye to card hamare yahan chalta nahi hai. However, if you have a unique card design, if you'll say that okay, this is Ayushman card, they will probably entertain you. Not probably, they will entertain you. And they will entertain you, they will provide you the services. So there is a functional benefit. Of course, there is some kind of cosmetic benefit also, but there is definitely I would say 80% there is a functional benefit of using this card. So while we can have this hypothesis that okay, this may be another kind of card, it is okay. 20 rupees if you spend if they are made aware, IEC में खर्चा होता ही है, 20 रुपया तो आप पर बेनिफिशियरी खर्चा कर ही सकते हो. 20 रुपया multiplied by if you have 10 crore families, this is 200 crore रुपया. Or if you have 50 crore, one time it is 1000 crore rupees. So that is, an NHA has told that if 100%, so we do not want, like you said that you have already issued a card, many of the states have, we said that we do not want to put an additional liability on you. NHA will bear the 100% cost of these cards. And if you are willing to issue now some states would say that why would I differentiate between, now suppose if a state is implementing USC and say that okay, I am implementing a larger beneficiary set, आप किसी को ये वाला कार्ड दोगे, वो लाल पीला हरा उसको अच्छा लगेगा, कुछ लोगों को आप नहीं दोगे. Why would I differentiate between them? So we have come up with the idea that okay, in that case, what you can do, you can ask her to issue card to everyone. We will issue the card to everyone on our system. We will pay 100% for everyone, even for those beneficiaries who are your state beneficiaries. So now there can be also, you can extrapolate the thing that okay, this is some kind of thing to expand the information about PMJ, but on the heart of it, there is definitely a functional requirement. That is why we are now in the fourth year of implementation, we strongly feel that beneficiaries of PMJY should possess some kind of card which would probably tell them that you are the beneficiary of PMJY. You are the beneficiary, and which this card they can, it's a more of a sign of empowerment or entitlement. Can we go back to this first slide? Yeah. So these are figures, all of you are aware. Next slide. Again, come back. Next slide. Okay. So this is the, again I will take questions subsequently, but I will tell you what we have done to improve, like tagging is one of the activity. Now what we have done, we were very sacrosanct about the database. You said privacy and all, right? But there is RTI also, which says that the गवर्नमेंट के जो लाभार्थी हैं उनका नाम, इवन द जेनेसिस ऑफ आरटीआई राजस्थान आपके यहाँ से ही आया है, जिसमें बहुत क्लियरली था कि जो मनरेगा होता था उसके जो बेनिफिशरीज हैं उनका नाम ग्राम पंचायत के बोर्ड पे लिखा होना चाहिए, राइट? So at least people should know that who are the beneficiaries of. So what we have, so okay, privacy means that I will not tell that this person is having cancer or this person is having some disease, but at least everyone should know that this person is eligible under this scheme. Because if some random person having a BMW, we get multiple. Now there is a CAG audit which said that in a SEC database there are thousands of beneficiaries who are having, like cars and everything possible. So if you hide everything, then they will continue to have all the benefits. They will never know कि अरे यार ये भी है. So for social audit, it is very much important that the beneficiary database is made public. And Supreme Court also has agreed about that. There is no such hiding. There is no such, there is no such there is no privacy here. Okay, privacy is when you say them कि इसने जो है, even what we have done, now we have published also that ये बंदा जो है आयुष्मान भारत में इस अस्पताल में जाके इलाज लिया है. क्या इलाज लिया है वो हम नहीं बताए हैं, but इलाज लिया है. And how it is going to help us? It is going to help us that tomorrow, now what happened, and again please do not quote me anywhere, till 2 months before we were having 8.5 lakhs hospital admissions per month. Now what we are seeing that it has shrunk automatically to 6.5 lakhs all of a sudden. And how it was done, I don't know. Aadhaar has now been made mandatory. So we suspect that there is, please do not quote me or record in this, we suspect that 20 to 30% there is fraud going on. And unless you do such kind of social audit, you ensure there is technology being used, like Aadhaar authentication, you put up the record, at least वो देखेगा कि यार मेरे नाम पे तो hospital ये कर रहे हैं, hospital admissions book कर रहे हैं. So this would be made aware. So please understand that we have a very genuine reason to ensure that the databases are made to the extent which is not orthogonal to the statements of privacy statements are at least made public. So now this is what we have done. We have also we have onboarded 4 agencies apart from CSC and UTI ITSL. We have for card creation. We have got 8 agencies for card approval. We have developed a BIS system which allows, till the date it was you were required to go to the CSC center or the hospital to get your card. Now you can get your card at your home itself. You can do the Aadhaar authentication, get your card yourself. So that is also we have made enable. And come down. Yeah. Last year we have Aapke Dwar Ayushman is this one. Bipul sir last day explained it to you that we have been able to create almost 4.21 crore card. Our momentum was broken by the second phase of COVID. Before that we have reached up to 9 lakhs card per day. Next slide. That I explained it to you. Next. Okay, so this is what we said, that co-branded card we are willing to pay for everything. And I know this is not about payment. This is hardly 20 rupees. So those states who are willing to issue, they can definitely. It's more about administrative approval, which whenever it is provided, we will be in a position to issue. Next slide. Yeah, fine. This I have already shown to you. Now this open BIS, I told you we have migrated to a new BIS platform which says that we have a self-assisted verification. You can yourself do a verification yourself based Aadhaar authentication. You do not require to visit any center for that. You can download your card also. Next slide. We are also doing what we have done, we have merged multiple databases. We got the Ujjwala database from PMUI, we have got PM Awas Yojana database, we have got central Ration Card database of all 19 crore families we have got centrally. And what we are seeing, and you will be surprised, there are lakhs of people, smart people, what they have done, they have enrolled themselves as SECC beneficiary also, and they have enrolled themselves as Ration Card beneficiary also. So those states who are implementing two databases, like SECC plus non-SECC, let me tell you, if you do not implement it on a common IT platform, you are going to suffer. And suffer in a very bad way. Why it is? Because these smart people what they have done, Aadhaar would ensure only individual identification, that Rohit Jha should not be able to get benefit twice. Rohit Jha ka ek hi card bane, but Aadhaar would not ensure that Rohit Jha ka parivar should not divide in two parts. Two of them would avail services as SECC beneficiary, and two of them will avail services as Ration Card beneficiaries. And your system will never be able to find out that these two people, 4 of them are the part of the same family, unless you have a common ration card or something holding them together. अच्छा ये ration card 2 इसका भी और 2 इसका भी, चारों का तो ration card एक ही है, तो ये 5-10 lakh का benefit क्यों उठा रहे हैं service योजना में? And we have identified lakhs, I don't want to quote the numbers here, lakhs of such individuals who have, after this deduplication exercise which we have been doing for last 6 months, who have very smartly done this. That they have divided their family, half of them idhar, half of them udhar, and they have doubled, tripled, 4 times. Where there are 3 kind of databases, they have 3 times they have got the entitlement. Next slide. Ujjwala also, we said that Ujjwala, we have been able to identify some kind of database and all this, right? Next. So this is we have a target of issuing 22 crore Ayushman card by the end of 2022, December 2022. We have got the database from the majority of the states. Now we have a monsoon here, so it will work like a sort of, it will break our initiative. However, wherever possible, we are going ahead with this. We have another 6 months left with us. So those states like Goa, even what is that called? We have states like Gujarat. Maharashtra also has already has issued 70 lakhs Ayushman card, and for rest of them they will be sharing the database with us. And now only few states are limited to share the database with us. They will subsequently share the database, and we will address the state-specific issues. Please understand this is important for us, and we are being every day it is being followed from the highest offices, including the Cabinet Secretary, Government of India office. We have a weekly meeting chaired by the Cabinet Secretary, where he takes a stock of how many cards have been issued. So that is why we are also, NHA as an organization is under tremendous pressure to deliver on this point. I request all of you to kindly support, and if you have any queries, all of us are here to sort it out. It is at the end of the day, please understand, it has 80% functional worth. So thank you very much. This was all about my presentation. If there is any query, I will address that. I will try to address that. Yeah, please, Dr. Nagankar, बताएं. Yes.
Card or passbook, we are giving a facility with unlimited BSI.
Yeah, right.
Does our software has a provision of our deduplication? If that same family
deduplication, तो उसमें ESIC वाले जो भी बेनिफिशियरी आते हैं तो इंडिविजुअल लेवल का आइडेंटिफिकेशन हो जाता है, लेकिन मैं वही बता रहा हूँ आपको, होता क्या है, जब तक आप एक परिवार के लेवल पे, देखिए इंडिविजुअल लेवल पे आपने आधार मैंडेटरी कर दिया तो इंडिविजुअल का पकड़ा जाता है कि भाई वो आदमी एक ही बार आएगा सिस्टम में, लेकिन परिवार के लेवल पे भी यू नीड टू हैव अ यूनिक आइडेंटिफायर, एंड राशन कार्ड इज द बेस्ट यूनिक आइडेंटिफायर एट अ फैमिली लेवल. So if you mandate for like now wherever the people are now implementing on our system, we are convincing them that please mandate Aadhaar and ration card both. अगर आप राशन कार्ड मैंडेट कर देते हैं, we are integrating it through API. So whenever someone enters the ration card, it will pull out the whole family detail and say that अच्छा तुम्हारे परिवार में इतने सारे लोग हैं जिनके अगेंस्ट ये आधार है, इसमें से 2 लोग पहले ही यहाँ वेरीफाई हो चुके हैं, 2 लोग यहाँ, सिस्टम will automatically merge the records. So we are not taking any punitive action right now. What we are trying to do that
records are somehow converged to see that we have a clean number of database. So आप देखे होंगे कल डेप्यूटी सीओ सर के प्रेजेंटेशन में देखे होंगे कोई स्टेट 110, 120, 130% तक बेनिफिशियरी को ये कर रहा है, कार्ड बनाया. हाँ, वन ऑफ द रीजन इज कि 2011 के डेटाबेस के आधार पे वो था, बट देयर इज ऑल्सो अ रीजन, मेजॉरिटी ऑफ द केसेस देयर इज अ ह्यूज ओवरलैप बिटवीन SECC database and other database which you are implementing, but in absence of any common identifier you are not able to find out कि वो कौन है, वो कॉमन लोग कौन है. ठीक है, तो ESIC वाला अनलेस एंड सिंस ESIC इज बीइंग इम्प्लीमेंटेड बाय सेंट्रल ESIC, सो जब तक वो अगर बोल दें कि राशन कार्ड मैंडेटरी कर दो सबके लिए तो हम कर देंगे, और हम कर देंगे फिर वी विल फिगर इट आउट. आपको मैंने बताया CGHS तक में लोग जो है PMJY के बेनिफिशरीज हैं. सो दैट इज द एंड दे हैव गॉट द कार्ड. आई डोंट नो व्हाट इज द रैशनल, बिकॉज CGHS में तो अनलिमिटेड बेनिफिट है, तो व्हाट इज द रैशनल दे गॉट द कार्ड फॉर व्हाट रीजन आई डोंट नो, बट दे हैव. और कुछ? Okay, so thanks Amit, because of you I could, yeah. We can have a one-to-one discussion about that, no issues. I understand that states have some genuine reservation about the process.
Regarding every benefit taken by any beneficiary, every state, there is a section of access to open well.
कर ले.
That is already in the state, so it's not hide.
हाँ तो ठीक है, बढ़िया है फिर तो. So my point is that again, like I end my presentation with that, with a very humble request, please support us because we urgently require this to be done. And yesterday the CEO NHA has also emphasized, at least 20% of his speech was on this topic. So we request all of you to please support us with this regard. Thank you very much for your presence.
One or two small things, Amit. In fact, you raised the point that Janadhar authorities might raise an objection to sharing the personal information. So yeah, last year, in fact, through very hard work and efforts of our CEO, we got a OM issued through UIDAI, wherein they have clearly stated, and in fact, that is the facilitator in the entire process. The issue that we were facing was that NFSA data, we were not getting access because the states were having some resistance in sharing the data. So what that OM states, OM says that any information collected by any government authorities in the name of the President of India. So the President of India and all ministries and the departments, in fact that is more concerning central government, but many of these schemes are central sector schemes or central funded schemes. So it states that any information collected in the name of the President of India can be shared because all ministries are working in the name of the President of India. So one ministry's information can be shared, including the Aadhaar data, with other ministries. The only thing is at the time of use of that Aadhaar data. So in case I am using any Aadhaar data and in fact the beneficiary starts taking treatment, the use of that card, till the time of authentication there is no issue, but use of services, that time the beneficiary's consent has to be asked, whether in fact if we have sought his concurrence or consent for seeking his Aadhaar details for a ration card purpose, then while availing the services under PMJY, the beneficiary would be asked whether you are giving your consent for seeking services under PMJY, because this Aadhaar information that we are fetching is based on the information sought from some other department. So this is one. So I think that OM might facilitate your discussion with your Jan Aadhaar authorities and sharing the information, because this information is a public good. In fact, when the government is providing some services, the Consolidated Fund of India or Consolidated Fund of State is getting used, then the respective government has all the powers and discretion to know as to who is availing the treatment. So beneficiary information is something that we need to share in the name of privacy. It should not happen that we restrict the use of information, because that would deprive the power of Aadhaar to be utilized for other purposes. So that is the first thing. Second is regarding your card creation. As Rohit clearly mentioned, we are ready and we have agreed in fact to share the cost of Aadhaar card, of Ayushman card creation for even the state beneficiaries. And as Rohit mentioned, in fact a few of the states have come forward and raised a request to provide portability services to their state beneficiaries. The beneficiaries who are not funded under PMJY also, they have come forward and requested, and in case you also wish your beneficiaries, if your scheme beneficiaries, you wish them to avail benefits across the country. So this would be an empowering provision and a uniformity of the card design. Whatever branding you have to do, there are clear-cut co-branding guidelines wherein no state would have any objections, because we are providing equal space, equal size logos, and your scheme name also is co-branded. It is I know that things might not be in your hand, but please convey it to those who matter that this is something which is in the interest of the beneficiary. We should have a beneficiary centric view rather than have some other priorities while we take any decision. And all states may please provide to us the information of your scheme beneficiaries in case you want the portability services to be extended to your beneficiary. We'll be more than happy to accept that and provide that facility to you. Thank you very much.
Thank you very much, Rohit Jha, sir. Now, ladies and gentlemen, we would be having Mr. Amarjeet Cheema, IT Director, NHA. He would be joining us online for a presentation on new developments on IT Platform 2.0 and e-Rupee. Thank you.
Good morning, everyone. So in this presentation, I'll try and talk about issues related to health benefit package. I'll also talk about some of the more recent innovations that we have done related to the ICD, DRG, and the quality innovations. But also I'll talk about a little bit in terms of some of the issues that were emerging yesterday related to either strategic purchasing or the pricing of some of the new health benefit packages that have been incorporated in HPP 2022. Next one. So this is something that I don't need to emphasize again. I think all states have made presentations, and we know that different states are at different versions of the health benefit package. Rajasthan at 2.2 and the others either at version 2 or the earlier version. Next one. Next one. But what I want to spend more time on is the process that was used in order to adopt HPP 2022. And the way that we did it was, the first part that we did was that we reviewed the entire set of utilization patterns that were available to us through the data, that which are those packages that are getting utilized, which are the packages that are not getting utilized. And then we tried analyzing that whether the lack of utilization for a particular package is because of a low price, or it is because that there is a low burden of the disease, or it is because there is the nomenclature of the disease, the procedure is such that it is no longer obsolete. So we tried looking at the reasons why there is low utilization for certain things. Secondly, previous slide only. Secondly, we tried analyzing the unspecified packages, because till version 2.2, till before December 2021, a lot of packages were getting booked as unspecified. So we tried looking at what are the etiologies, what are the procedures, and what are the disease conditions for which these unspecified packages are getting booked. Third, we reviewed the entire set of state-specific packages, and we looked at within each specialty which state-specific packages are getting booked, and which of those state-specific packages are quite large in terms of the number of utilizations. So this actually led us to propose or to discuss that which additional packages need to get incorporated. We also, for example, when there was a discussion about palliative medicine packages, we also looked at that within our oncology packages, more than 35% of all patients are actually coming in stage 4, and they have needs for palliative care. A lot of the unspecified packages that are being booked were all related to therapeutic procedures that fall within the IR domain, intervention radiology. Now the second thing was, we tried making a comparison across the cost and the price, and it is important to distinguish between these two, because a lot of times that we actually make a comment about whether the price is appropriate or not appropriate, we actually reference that against prevailing prices in other settings, and those are like basically price benchmarking. What we tried to do was that we actually measured what is the actual cost that goes into performing a given procedure, and then trying to look at that how different or how close is the price as against the cost of performing that procedure. And this evidence on cost comes from a large study, which is the first nationally representative study that was undertaken in India, which was funded by the Department of Health Research. Data was collected from close to about 100 hospitals in about 14 states. And these hospitals belong to both public and private sector, tertiary care medical colleges, district hospitals, and private sector hospitals. Private sector hospitals were all from tier 2 and tier 3 cities, usually around 200 bed size capacity. So they were not the ones who are the corporate hospitals or the bigger ones. And we tried doing this cost price differential given the evidence that came from this particular study. And this study was reviewed by an international set of experts who were commissioned by the NHA, who came from the Global Health Costing Consortium, and they gave their report on the processes and the methods that have been established. Findings of the study have been published in peer-reviewed journals. About 5 of the papers have already been published from this particular study. So it's quite a robust data which has now been used by the DHR to set up a national health system cost database. So I'm just saying this just to instill confidence that the evidence that comes from this study is reliable. And it is not the price comparison that we are doing across different hospitals, what they are charging. Then the third that we did was that we took a lot of feedback from the stakeholders. So we invited feedback from states. So some of the states gave us a set of proposed prices that they felt would be more appropriate for each of the health benefit packages. So Kerala was one state that gave us for almost all specialties. There were some other states who also provided us with such feedback. We also obtained feedback from other private sector players as well, like FICCI, CII, AHPI, who also gave us their own set of representation that these are the rates that they felt should be more appropriate for the purpose of prices under the HBP. And all of this evidence we presented to our specialist expert groups. And these specialist expert groups, based on the information that was available, they deliberated on it. And they ultimately defined which procedures should be incorporated, given the fact that they are currently being booked as, let's say, unspecified, or they are being used in the state-specific packages, or these are not there, but there is a lot of burden of these things, these conditions, and there are patients that they see very commonly in their routine clinical practice. So that was the reason that led to incorporating certain health benefit packages into HBP 2022. And the pricing is quite significantly dependent on the costing evidence that came from the study, supplemented by the consultations that took place. And I must inform that the prices that were submitted by the AHPI, FICCI or CII, they were like almost 3 times, 4 times of what we have actually set right now also. So